So topic is very simple. That is acute bacterial meningitis. Actually, this case will not be given in the practical examinations. In practical examination, acute bacterial meningitis will not be given. So what is the importance of knowing these topics? This is for theory paper number 1. Number 2, in future when we will be doctor, then we will have to deal these type of cases. So there are two purposes for this. Purpose 1 for passing in the exam. Purpose 2 for diagnosis of the cases in future. So the term is that acute means sudden. Bacterial means bacterial infections. Bacterial infection caused by the bacteria, and meningitis means the infection occurs in the meninges. So in the case of acute bacterial meningitis. Okay? So remember, there is a specific term called tuberculous meningitis. It may be acute or chronic. Tuberculous meningitis, then fungal meningitis, viral meningitis, lots of other meningitis are there. Today's discussion on the basis of acute bacterial meningitis means some bacteria which are very virulent, causing the meningitis and inflammation of the meninges. Now let us think of two groups of people. One group is the newborn people, another group is say children of age 3 years. Okay. Now remember, I will give you one handout of my lectures. Handout means very short discussion of these topics. Okay? And this is the handout I will give you. And you can take this. Actually, these are prepared from the most recent edition of Nelson textbooks. I get this. In short, in gist of the topics. And before that, I will discuss everything. Sites are there. But before going to the sites, you should know something about what I am trying to tell from my own experience in the clinical management of the cases. We divide the cases of bacterial meningitis into two groups, in neonatal meningitis and in older children, say 3 or 4 years old meningitis cases, how they present to us. In case of neonates, usually they present with a poor sucking, poor feeling, lethargic, and sometimes they are suffering from hypothermia. Remember, in newborn, the most common infection sign is hypothermia. Hypothermia or fever is common in the older children, but hypothermia is more common in the newborn. When you find a newborn with hypothermia, you think of either the baby is exposed to cold or the baby is suffering from food deficiency, or the baby is suffering from some infection giving rise to hypothermia. Okay. So in newborn may present with say lethargy, weakness, poor feeding, hypothermia, and usually in that cases we usually diagnose is at neonatal septicemia. It means neonatal infection spreading to the blood to the whole system. And you know the terminology is bacteria means bacteria in the blood. Septicemia means bacteria in the blood with features of infection. And sepsis means when the infection is localized and damaging some system. When we utter the term sepsis, it means it is damaging some system. Now, in case of septicemia, near about 1/3 of newborn baby, they develop meningitis. So you will not get the features of meningitis like older children in case of newborn, but you should suspect that this baby, as the 1/3 of the baby of the neonatal septicemia is suffering from meningitis. So in every newborn baby suffering from septicemia, you should do the investigation for meningitis. This is the first half of the picture. Second half of the picture, say 2 years old boy is presenting to your OPD or to your clinics with fever, toxic look, lethargic, and with or without history of convulsion. Convulsion history may be there. And when you examine the baby, you will see the neck is very stiff. Neck is very stiff because all the meninges are inflamed, and meninges in the brain and spinal cords are all inflamed. So the nerve root which is coming from the meninges, coming from the spinal cord or from the brain to the different structures, periphery, they are also getting some inflammatory changes and they will irritate. Okay. For example, these neck muscles, the trapezius or the sternocleidomastoid is supplied by the cranial accessory nerves, and it is coming out through the accessory nerve is coming out through foramen magnum. So 11th cranial nerve, accessory nerve, there are two parts. One is cranial part and another is spinal part. Cranial part actually mixed with the other nerves and supply the laryngeal muscles. But the spinal part, it comes out through the jugular foramen, supplies the sternocleidomastoid and then passes to the posterior triangle of the neck and supplies the trapezius. So if this nerve is irritated, then there will be spasm of the trapezius muscles. So why there is neck rigidity in meningitis? This is due to the spasm of the muscles, trapezius muscles or sternocleidomastoid muscles. Why it is so? Because the nerve root is getting irritated. Which nerve root? That is spinal accessory nerve root, which supply the trapezius and sternocleidomastoid. Is it clear to you? Similarly, if you straight the leg, patient is lying on the bed, you are straightening the leg. In that case, what will happen? You will see the child is suffering from pain. That is called Kernig sign. Kernig sign. So, in case of say, so in case of say meningitis, if you flex the neck, it is very difficult to flex. Because of the contraction, because of the spasticity of these muscles. Okay. And in case of Kernig sign, suppose he is lying and if I make the knee straight, he will suffer from pain. Why? Because the sacral roots of the nerves, they are going down and they are getting irritated by the inflammation. So, is it clear? So, this type of sign you will get in case of meningitis. And most important thing is that meningitis sometimes giving rise to convulsion because of the irritation of the brain. Because you see the meningitis have three components, dura, arachnoid and pia. So if they are inflamed, then the brain cortex also inflamed. So there will be convulsion may be there. And sometimes you will see some abnormalities of the children in case of meningitis. For example, some child may develop sensory neural deafness, particularly if the infection caused by Haemophilus influenzae type B. Age influenza type B, it can give rise to sensory neural deafness. For postgraduate entrance examination, this type of questions will come. So, Haemophilus influenza type B can give rise to deafness, and also the neurodevelopmental disorders. It means some types of abnormal behavior, sometimes of say hyperactive behavior, sometimes of say autism or self-centered behavior. That may be one of the complications of these things. In other way, there may be involvement of the optic nerve can give rise to blindness. There may be convulsive disorder, epilepsy, secondary epilepsy, that may occur following meningitis. Or there may be hemiplegia, one-side paralysis, or monoplegia, paraplegia, and weakness of the motor function. That may occur in the case of meningitis. Usually, these type of meningitis are preventable. How it can be prevented? By giving the vaccines. Now the Haemophilus influenza type B vaccine is a government vaccine. Government is giving that. Pneumococcal vaccine, they are also government vaccine. UIP schedule, that is, it is preventable vaccine. Only one thing remains, that is the meningococcal vaccine, not recommended for all, only in special situation. Suppose a healthcare worker, they can take the meningococcal vaccines. Who should take the meningococcal vaccine? হ্যাঁ গুড বুঝছো তাহলে আমাদের কি করতে হবে আমাদের we should find out the diagnosis of the meningitis and go to so preventable disease that is very important. It is preventable disease and also sometimes some viral infections and mumps can give rise to asymptomatic meningitis. Measles can give rise to meningoencephalitis. Japanese bee virus can give rise to meningoencephalitis. Vaccines are available on all these cases. So vaccine can prevent this. And whenever you get a case of meningitis, you should immediately diagnose the meningitis cases. By doing the blood examination, I have told you, you will get the features of septicemia like, say, total count will be increased, C-reactive protein will be increased, vocalcitonin, inflammatory markers, they will be increased. And if you do the lumbar puncture, it means CSF study, you will get the features of meningitis. Bacterial meningitis, usually you will get the polymorphs count is very high. Whereas in tuberculous meningitis, you will get the lymphocytes count are very high. Okay? And definitely, the bacteria utilizes the sugar in the CSF, so sugar count will be low. They used to eat sugar in the CSF, so sugar count will be low. But in viral meningitis, sugar count is usually normal, except asymptomatic meningitis of mumps, where the sugar count may be low. Okay. Management usually given by the antibiotics starting from the very beginning. For gram-positive organisms, usually we give 7 to 10 days antibiotics, and for the gram-negative, we give usually 14 days of antibiotics. Remember, when we treat the patient, sometimes we see that even after the initial remission, after 7 or 10 days, even at the end of the when we are trying to discharge the patient, at that time there will be relapse of the fever, there will be relapse of our headache, etc., vomiting, etc. Reason is that there may be some abscess, brain abscess may be formed, infection, or there may be some effusion, subdural effusion may be there, or empyema may be there. So with this brief introduction of our experience in day-to-day practice, we are giving the slides now. Let us go to the slide itself. So you see this is very easy, the infection of the meninges, that is discussed before, right? Infection of the meninges giving rise to brain and spinal cord inflammation. We have discussed it may occur in infants and children. Though we are very much aware of the older children, neonatal meningitis will be dealt later on in neonatology. Now, vaccination, I have told you the Haemophilus influenzae and the pneumococcal vaccines and meningococcal vaccine, not for all, only for health worker, reduce the incidence of the meningitis. Okay. And seasonal geographic variation may be there. Suppose at this time there are chances of more exposure. Common pathogens by yes. This is theoretical. Now in neonates, usually E. coli group B streptococcus. Gram-negative organisms is more common in neonates. But in older children, you see the streptococcus pneumoniae, meningitis, age influenza type B, etc. And immunocompromised. Suppose somebody is suffering from sickle cell disease, or some thalassemia, or the malnutrition, or some say relief from the cancer, or steroid therapy, nephrotic syndrome. Immunocompromised means so those who are immunologically suppressed. In those cases, you may give this type of pseudomonas, listeria, and fungal cases may be there. This is for just discussion, and sometimes it may be asked in the exam also. In the newborn, which bacteria gives rise to usually meningitis? You should answer it is gram-negative bacteria. In older children, previously it was Haemophilus influenzae type B, Neisseria, or meningococcus, etc., pneumococcus, etc. But nowadays the bacteria are changed. Other bacteria are. That depends on what is the culture result of the CSF. Culture cannot go there. Otherwise, it is very difficult to say. But this you should say. Now, how the bacteria enters the meningitis? Usually, there is nasopharyngeal colonization. Or there is some adhesive factors on the bacteria. They enter to the mouth. In the pharynx, there is colonization of bacteria. And taking advantage of any reduced protection of the child, bacteria enters in the blood, then it enters in the brain, meningitis. Okay. So, bacterial blood-brain barrier causes the blood-brain barrier, and multiplication is CSF due to limited immune response. Remember, whenever the bacteria is multiplied in the CSF, means CSF is present in the ventricle and subaqueous spaces, and when the bacteria multiply in the CSF, there will be protein level will be high because of the exudation. And when the protein level will be high, there will be addition of the CSF orifices. In pyogenic meningitis, we have seen the subaqueous spaces are full of pus. So they prevent the absorption of the CSF. So in case of bacterial meningitis, subaqueous spaces is full of thickened material or pus, without say the infected material present there, and that can give rise to poor absorption of the CSF fluid. And if there is poor absorption of CSF fluid, there will be hydrocephalus. And as it is communicating from the ventricle also, there is no obstruction of the flow, but absorption is deficit. It is called communicating hydrocephalus. So then this is a question. So in case of bacterial meningitis, the hydrocephalus origin is communicating type of hydrocephalus. But in case of tuberculous meningitis, the base of the brain is exudation is high. Base of the brain exudation. Basal exudation is high. Not the above. Basal exudation is very high. That is also one type of communicating hydrocephalus. There may be another hydrocephalus that is obstructive hydrocephalus. Suppose mumps virus, mumps infection. That can block the aqueduct of Sylvius. That is the communicating tract from the third to fourth ventricle. Aqueduct of Sylvius. Okay. So aqueduct of Sylvius, third to fourth ventricle, third ventricle to fourth ventricle connection, that may be obstructed. That is called obstructive hydrocephalus. Or it may be due to some space occupying lesion pressing the aqueduct, that can be based to obstructive hydrocephalus. So we are not going to that. Bus. So this is a pathophysiology. You know the pathogenesis, and this is a pathophysiology. Exudate, and definitely there will be increased intracranial pressure. Right? Intracranial pressure will be increased because of the exudate, and there may be inflammation of the small blood vessels. So small blood vessels inflammation, vasculitis will be there, and there will be, as the blood vessels are small blood vessels, penetration can give rise to thrombus formation. So infarction is common. Infarction is common also. And you see the cranial nerve palsy. Particularly the cranial nerve which traverses a long distance. The sixth cranial nerve, abducens nerve. It takes origin from the pons. Hooks down the origin of seventh cranial nerve. Then it traverses forward, crosses forward, and comes in lateral relation of the cavernous sinus, and then enter the orbital fissures, and then supply the lateral rectus muscles. So it crosses the long tract. So there is every chance. In case of any inflammation in the brain, sixth cranial nerve is very commonly involved. The reason is that. Similarly, another nerve is seventh cranial nerve. This is not for abduction reason, but it has been found the seventh cranial nerve is very commonly involved in this type of illnesses. This is statistically approvable fact, 6 and 7. But there may be chances of involvement of the third cranial nerve, chances of the fourth cranial nerve, etc. So don't, any cranial nerve may be involved, but these are the common cranial nerves which are involved. Now, hydrocephalus and subdural infusion, I think I have discussed before. So, there is no problem about that. Clinical features, I have also discussed these clinical features. In case of, say, small baby, you will get this type of clinical features. And I think you can make it also same. You can synthesize it also. See, the infection is there. Seizures means some say convulsion or some altered behavior. Not all seizures are convulsion. Seizures may be some behavior alteration, some sensory alteration, some type of abnormality we just see. But convulsion means some motor jerking is there. And so altered mental status. Child may be drowsy also. In older children, maybe this is it. In older children, you see the headache, neck stiffness, Kernig signs and Brudzinski signs. Kernig signs means when you flex the head, suppose this is the head, sorry. When you straight the leg, when you straight the leg, then there will be pain because of the lumbosacral root. And in case of neck stiffness, because the nerves are coming to the jugular foramen, in the jugular foramen, large number of nerves are coming out. That is 9, 10, 11 and 12. These 4 nerves are coming out to the jugular foramen along with the internal jugular veins. Okay? They are coming out. When they come out as a branch from the jugular foramen, then they disperse. So if they are getting irritated, there are chances of the stiffness of the trapezius muscles can give rise to neck stiffness. Brudzinski signs means if you flex the neck, the knee will also be flexed. Okay. So these you can see by the clinical methods, by McLeod's clinical methods, they are giving these pictures of all things. McLeod's clinical methods, they are giving pictures of this type of Brudzinski sign, neck stiffness. It's a very good book. Okay. Next, you go to the severe presentation, means I discuss if the presentation is meningococcal infection. There may be hemorrhage, spots throughout the body, and features of shock may be there, and then a rapid progression to death also. So sometimes meningitis patient may present in the last stage and they will be dead. Nowadays there is another organism, there is the Staphylococcus organism, that is also causing large number of meningitis cases. And we have seen the meningoencephalitis, 38.4% cases of meningoencephalitis in 2017 in our medical college. Study done for 1 year, 38.4, 2017. In Gorakhpur, it was 68.4, Staphylococcus. That is also common in older children, not for the newborn or the other smaller children. Differential diagnosis, we have discussed, everything will be there. Viral, tuberculosis, there may be vein abscess, encephalitis, subacute hemorrhage, they will come in differential diagnosis. Anything which involves the brain giving rise to convulsion, that will come in differential diagnosis. So diagnosis most important is the clinical suspicion, and we usually diagnose the lumbar puncture. And as nowadays, it is not during our period, as nowadays there are say investigations are available, MRI, CT scan, etc. You can do the neuroimaging study also. Find out whether hydrocephalus is present or not. For example, in the case of tuberculous meningitis, if you can detect the hydrocephalus in the very early stage, and if you do the ventriculoperitoneal shunt, immediately the patient's condition is stable. We have diagnosed a case of say 2.5 years with tuberculous meningitis. Immediately ventriculoperitoneal shunt done. Now the age of the child is 28 years and he is an engineer and doing his practice. No problem. Okay. So remember everything, you should be very much careful about this. Now remember for lumbar puncture, suppose in case of meningitis we have seen there is a raised intracranial tension. That is, intracranial tension means tension in the brain is high. Okay. And you know the brain contains the brain itself, some fluid and the blood vessels. Any of them, if it is increased, it can compress the brain because brain is in closed cavity. So if the fluid is increased because of infection, large which is exudation is there and compress the brain, it will increase the intracranial tension. And during that time, if you say do the lumbar puncture, what will happen? The brain may penetrate downwards, giving rise to herniation. Is it clear to you? Why the intracranial tension is raised in meningitis? We should arbitrarily treat the child. Okay? Or we should treat the child to reduce the intracranial tension, and after reduction we can do the lumbar puncture. But CSF study is must. We will have to do CSF study for diagnosis of the meningitis. What is the CSF findings? Naturally, it is a bacterial infection. So what is the CSF findings? You see the high WBC count. I think there will be no confusion. I think the high protein is discussed, and the sugar will be low because bacteria is eating the sugar as their food, and positive gram stain or culture. Very easy to diagnose by these methods. Clear? Now go to the other cases. Say normal CSF, what usually see? In normal CSF, clear, low cells, normal glucose and protein. Okay, we should know what is the normal value of glucose and protein also. Usually normal glucose value is 20 to 40 and normal protein is normal protein is 20 to 40 and glucose is 50% of the blood sugar. Glucose is 50% of your blood sugar. So whenever you do the CSF sugar, you should do the blood sugar also. And if you see the glucose CSF sugar is less than near about 50% of the blood sugar. Suppose you are getting the 20% or 30% of the blood sugar level in CSF, it means hypoglycemic status of the CSF. Glucose level is low. Blood investigation, now blood culture, CRP, CBC means complete blood count, C-reactive protein, procalcitonin indicates the infection, and also do serology in specific infections. You can do the different tests. For example, in Staph typhus, you can do the antibody level, IgM antibody. Okay. Neuroimaging help like this. Lumbar puncture before herniation. Okay. So if there is any herniation chance, intracranial tension is high, you should not do the lumbar puncture. Infarct, hydrocephalus, empyema, etc. that can be diagnosed by this. Now, empiric antibiotic therapy. Suppose the diagnosis is difficult, you are not able to diagnose this, then you will have to give this empiric hydroxychloroquine. Decision drug of choice, this is discussed in different book, you will get different, but the most important recently is ceftriaxone and vancomycin we give, and listeria. If the listeria monocytosis, particularly in the newborn, the ampicillin is started with that. However, mainly drugs should be given based on the culture, which is not easy. Sometimes we get the culture, sometimes we do not. Specific therapy, how long the therapy should be given? Different bacteria will take different time. Streptococcus pneumoniae takes 10 to 14 days for the complete cure. Meningitis 7 days, influenza 10 days, negative 21 days. We made a common formula for our PG student, 7 to 10 days for gram positive organisms, and for gram negative is 21 days. If I ask my assistant professor how long you should give the treatment in meningitis, they will tell like this. Sir, 7 to 10 days for gram positive and 21 days for gram negative. I will not remember like this. Is there a role of steroid in meningitis? It is very important that steroid has some role, but provided the steroid should be given before starting of the antibiotic or at least with the first dose of antibiotics. What it prevents? It prevents the hearing loss. It prevents the inflammation. How it prevents the inflammation? Now, whenever there is infection, the organism is degraded. Or if there is any bacteria, suppose this is one bacteria, when there is infection, the bacteria antigen is degraded. Large number of antigen they will spread, and body will react by producing anti-inflammatory products. To destroy that antigen, body will react by releasing complement, by releasing lymphocytes, by releasing different cells, and that gives rise to damage. In the brain, there is a large number of phagocytes are there. They will be released, and they can give rise to damage. So damage in any system, not for the bacteria or viruses itself, but for the immunological system of the body also. Nowadays, there is a term known as autoimmune encephalitis, and we are getting this type of cases in autoimmune encephalitis, where there is some antibody produced against the NMDA receptors, and that is causing the damage. And pieces of encephalitis, particularly some bizarre presentation. So supportive care, ICU management for shock that you should do, seizure control, convulsion control you should have to do, and syndrome of inappropriate ADH secretions. Now, if there is meningitis, there are chances of more ADH secretion. If there is more ADH secretion, there will be more and more retention of water, and the more and more retention of water can give rise to excessive fluid load. Excessive fluid load, right? What is SIAD? What is SIAD? বলো না, পুরো নামটা বলো SIAD। ওই যে যেটা লেখা আছে SIADH, পুরো নামটা কি? কি শুনবো, তো বলা হয়ে গেছে, তুমি তো গল্প করছিলে। বাবা 200টা ছেলের ক্লাস নেওয়া অভ্যাস আমার, তার মধ্যে একটি ছেলেকে বাবা তুলতাম, একটি ছেলেকে বাবা তুলে বকুড়িয়ে দিতাম। সেই ছেলে প্রায় 20 বছর পরে হোয়াটসঅ্যাপে একটা মেসেজ পাঠালো, স্যার আপনার বকুনির জন্য আমি এখন এই পজিশনে এসেছি, আমার খুব ভালো হয়েছে। কি হয়েছে তোর? বলো, আমি আপনার বকুনির চোটে পড়াশোনা শুরু করেছিলাম, তারপর MBBS পাস করে আমি MS করলাম, তারপরে স্যার কার্ডিওথোরাসিক সার্জারি MCH করেছি, করে আমি স্যার অস্ট্রেলিয়া থেকে MCH এর ট্রেনিং নিয়ে এসেছি, এখন BMBতে সার্জেন আছি। কুন্তল রায়চৌধুরী এখন এই রিসেন্টলি একটা বড় অপারেশন করেছে, আমাকে মেসেজ পাঠিয়েছে, বুঝলেন? যাদেরকে বকছি তারা যে তাদের খারাপ কিছু করছি না, তাদের কাজে লাগবে পরে। হ্যাঁ, রায়চৌধুরী টাইটেল কিন্তু ওরকম তুলে তুলে জিজ্ঞেস করতাম, তুমি বাবা কেন উল্টো দিকে তাকিয়ে আছো? সরি স্যার, আর হবে না। যাই হোক, তাহলে এটা হচ্ছে SIAD, সিন্ড্রোম অফ ইনঅ্যাপ্রোপ্রিয়েট ADH সিক্রিশনস। আমি আর ওদিকে ICP শক এসব ম্যানেজমেন্ট ওদিকে বলছি না, ইন্টারনাল পেশা, এটা এর মধ্যে পড়ছে না, এটা অন্য পড়তে হবে, ঠিক আছে? Let us go to the complications. We have discussed there may be convulsion, there may be cranial nerve palsy, hydrocephalus, stroke and infarcts. Very common sense. This type of complications are just like common sense, you can do it. Subdural inflammation is one of the common complications of bacterial meningitis. Usually recover continuously. নিজে থেকেই চলে যায়, unless and until the diffusion is converted to pus. যদি subdural pus হয়, তখন তোমাকে সেটা বের করতে হবে। Otherwise, it is not needed to do any infection. They usually present with a relapse of fever. After 10 days of antibiotic therapy, everything is normal. Then the child is complaining of fever. And you do the CT scan or MRI, you see the subdural fluid. Now, if there is persistent of fever, more than 10 days, it means some other infection is there. Or your hospital-acquired infection, nosocomial infection, or there may be some abscess, or empyema, or your drug-induced fever. Vancomycin is a notorious drug, which can give rise to fever by itself. Similarly, gentamicin can give rise to fever. Gentamicin, vancomycin notorious, can give rise to fever itself. চিকিৎসা করতে করতে দেখছি যে জ্বর ছাড়ছেই না, you can give the vancomycin. Stop vancomycin and then লং টার্ম সিকুয়েলি, অনেকদিন পর কি কি হতে পারে? হিয়ারিং লস, ল্যাঙ্গুয়েজ কমপ্লিটলি, সিজার ডিসঅর্ডার, মোটর ডেফিসিট, যা মনে হবে লিখে দেবে, সব হয়ে যাবে। কারণ মেনিনজাইটিস হয় না এমন কিছু নেই। ব্লাইন্ড হয়ে যেতে পারে, হিয়ারিং লস হয়ে যেতে পারে, প্যারালিসিস হয়ে যেতে পারে, বুঝতে তো কি হবে না, সব কিছুই হতে পারে। তার বিহেভিয়ার অ্যাবনর্মালিটি হতে পারে, হাইপার অ্যাক্টিভ হতে পারে, এই সমস্ত। এখন তো ট্রিটমেন্ট খুব বেরিয়ে গেছে, সেজন্য মর্টালিটি খুব বেশি হয় না, কিন্তু নিউরো ডিসাবিলিটি কিন্তু নিয়ার অ্যাবাউট দেখো 50%। একবার মেনিনজাইটিস হলে তার ডিসেবিলিটি কিন্তু 50% হয়ে যাচ্ছে, একটা না একটা খুঁত কিন্তু থেকে যাচ্ছে। মর্টালিটি না হলেও মর্টালিটি কমছে, লেস দ্যান 10%। ট্রিটমেন্ট বেরিয়েছে, ভ্যাকসিনস এখন অ্যাভেলেবেল, ভ্যাকসিনস যেহেতু অ্যাভেলেবেল সেই জন্য ইনসিডেন্সও কমেছে অনেকটা। হিয়ারিং লস স্ক্রিনিং ইজ ম্যান্ডেটরি বিফোর ডিসচার্জ। হিয়ারিং লসটা কিন্তু খুব ইম্পর্টেন্ট, এবং সেই হিয়ারিং লসটা ইউ ক্যান প্রিভেন্ট। হিয়ারিং লস কাদের জন্য বিষয়? হিমোফাইলাস ইনফ্লুয়েঞ্জা টাইপ বি ম্যাক্সিমাম, তারপর নিউমোনিয়া, নিউমোকক্কাল মেনিনজাইটিস। তো প্রিভেনশন ভ্যাকসিন, হিপ ভ্যাকসিন, নিউমোকক্কাল অ্যান্ড মেনিঙ্গোকক্কাল ভ্যাকসিন, ঠিক আছে। কেমোপ্রোফাইল্যাক্সিস, মনে করলে মেনিনজাইটিস পেশেন্ট হয়েছে, কি দিয়ে তুমি বাড়ির অন্যান্য লোককে কেমোপ্রোফাইলাক্সিস করবে, যাতে অন্য বাচ্চাগুলো যাতে না হয় বা অন্য বড়গুলো না হয়, সেখানে রিফাম্পিন বা সাইক্লোফ্লক্সাসিন দিতে বলছে। অ্যান্ড হিবের যারা হিমোফাইলাস টাইপ বি যাদের, তাদের হাউস হোল্ড কন্ট্যাক্ট তাদেরকে দিতে বলছে, আর মেনিঙ্গোকক্কাল কন্ট্যাক্টে দিতে বলছে, ঠিক আছে। নামটা মনে রাখলেই হবে, আর কিছু দরকার নেই। CSF summary table that is discussed, দেখো তোমাকে বলতে পারে why not is viral meningitis, etc. But in case of bacterial meningitis, you see protein level is high. In viral, sometimes protein may be there, but glucose is normal. When glucose is reduced. In tuberculosis, lymphocytes, not WBC, lymphocytes are high. Rest are same. Okay. But in the first part of the tuberculosis meningitis, in the initial time, neutrophil may be less. সেই জন্যই একটু টিপিক্যাল হয়ে যায় না। আদার ফাইন্ডিংস পাবে তুমি, ইউ উইল গেট দি আদার ফিচার্স অফ পক্স। এখন তো সিমিনার দিয়ে তুমি টেস্ট করতে পারবে। ক্রিপ্টোকক্কাস মেনিনজাইটিস, ফাঙ্গাস, ইনডাইন অ্যান্টিজেন ডিটেকশন। এখন তো খুব বেশি হচ্ছে, যেটা সুইমিং পুল থেকে হচ্ছে, অ্যামিবা। অ্যামিবা যে সেখানে মেনিনজাইটিস করে ব্রেনটা নষ্ট করে দিচ্ছে, এবং সেক্ষেত্রে তোমাকে নিউট্রোফিল বাড়বে এবং মোটাইল অ্যামিবা অন ওয়েট মাউন্ট, তুমি দেখবে অ্যামিবাগুলো ঘুরে বেড়াচ্ছে, নেগেরেরিয়া জেনেস, এবং শেষ করে দিচ্ছে ব্রেনটাকে। সাউথে খুব রিপোর্ট হচ্ছে, সাউথ দেয়ার মোর রিপোর্টস ফ্রম দ্য সাউথ। Autoimmune enteritis I have discussed, that sometimes the body itself gives rise to antibodies, damaging the cells, and there is encephalitis are there. Now, neuroimaging, when you should do? If there is any papilledema, you should do ophthalmoscopic examination. If there is features of raised intracranial tension, papilledema, raised blood pressure, bradycardia, small type of breathing, respiratory breathings, mental status alteration, and there is a focal deficit, means only one monoplegia, or say hemiplegia is there. In that case, you should do the neuroimaging immediately. So, whenever you suspect any raised intracranial tension or any focal deficit, you should do the neuroimaging. So, what are the key learning points? Early antibiotic therapy, lumbar puncture before antibiotics, safe, start steroids in hip cases, vaccinate and screen hearing. Okay, these are key points of learning. Now, case vigilante example, এটার উত্তর দিতে হবে। কাকে উত্তর দিতে হবে? যে ছেলেটা ঘুমোচ্ছে পড়ে পড়ে, দেখো তাকিয়ে কি সুন্দর ঘুমোচ্ছে, দেখো কি করে ক্লাসে আসে, আমি কি বুঝতে পারি না কেমন ক্লাসে আছে, তুলে দেবে ওকে, এই কেসটা বলো, এই কেসটা বলো, রাত জেগে পড়াশোনা করে বলে এরকম হচ্ছে। কেসটা বলো, এই কেসটা কি আছে? চাইল্ড উইথ ফিভার, উঠে দাঁড়াও, দাঁড়িয়ে বলো, এদিকে তাকাও, এই কেসটা বলো। চাইল্ড উইথ ফিভার, ভমিটিং, ফটোফোবিয়া, সিজার্স, লাম্বার পাংচার সোর্স টার্বিড সিএসএফ। আরো এর পরেরটাও দিয়ে দিচ্ছি, সেটা বলো। সিএসএফ স্টাডি এইটা, কোনটা হবে সিএসএফ আমাকে সেটা বলো, কি পাবে তুমি? হ্যাঁ, কোনটা পাবে? এ পাবে না বি পাবে না সি পাবে না ডি পাবে, বলো। বি, প্রোটিন কমে যাবে, গ্লুকোজ বাড়বে। ও বি বলেছিস? হ্যাঁ বিটা ঠিক আছে, অপশন বি কারেক্ট। বস, তাহলে শুনেছিস, ঘাড় নিচে ঘুমোতে ঘুমোতে শুনেছি কি করে? হ্যাঁ বলো, এইটা বলো। Dexamethasone is not effective in preventing hearing loss in. Most effective. Correct. B. এটা বল, tuberculosis meningitis. হ্যাঁ এইটা একটা বল দেখি। আচ্ছা সবাই একসঙ্গে চাঁদা তুলে বললে তো হবে না, একজনকেও বল। এই তুই বলতো রে, এই তোর বই কি হলো? আজকে বই আনিস না? বই তো রাখ দিস তো আগে। এবারে এটা বল, কেউ বলিস না বাবা, এটা বল। আর টাইম নেই, আর 10 মিনিট মতো টাইম, তাড়াতাড়ি বল, এটা বলে দে। বল রে বল। এই 4 মান্থ, এই কেসটা বল, উত্তর দে। এই 4 মান্থ ওল্ড ইনফ্যান্ট আসছে, কেউ বলে দেবে না সাইড থেকে, কিন্তু ওর ব্রেনটা খাটাতে দাও। 4 মান্থ ওল্ড ইনফ্যান্ট, 4 মাসের বাচ্চা, প্রেজেন্টেড উইথ ফিভার, poor feeding, lethargy and convulsive seizures. CSF shows 1800 WBC per cubic meter, 95% neutrophil, 14 to 20 যেখানে 40 পর্যন্ত থাকে হাইয়েস্ট, 14, গ্লুকোজ 25, সেরাম গ্লুকোজ 95। হ্যাঁ ব্যাকটেরিয়াল কি? মেনিনজাইটিস, এনকেফেলাইটিস, কি বলছিস? তাড়াতাড়ি বল। অ্যাকুট ব্যাকটেরিয়াল মেনিনজাইটিস, কনফিডেন্স কম কেন? অ্যাকুট AB, actually CSF study, AB finding is very low. Only in 10 to 20% cases you will get AB. So AB may be negative. So your answer should be tuberculosis meningitis. এটা ঘাবড়ে দেওয়ার জন্য করছে। এটা বল। 10টা রুমে তাদের আছে, একটা ডরমিটরিতে আছে হোস্টেলে, একজনের মেনিনজাইটিস হয়েছে, 10টা রুমে আছে, তাদেরকে তুমি কি ওষুধ দেবে? Besides rifampin, you can give ceftriaxone single dose. Ceftriaxone single dose you can give. So your answer should be ceftriaxone single dose. Very good answer. Hearing assessment. দেওয়া হয়নি dexamethasone, তাহলে এখন তুমি কি করবে? হ্যাঁ, তাহলে এখন do not give as antibiotic. Answer should be D. তাহলে বুঝতে পারছো, এইগুলোই MCQ। আর পরীক্ষাতে তোমাদের পিজি এন্ট্রান্স একটা কেস দিয়ে দেবে, লম্বা কেস। কেসটা ফালতু বানাবে পুরো, ওই কেসটার মধ্যে উত্তর দেওয়া থাকবে, কি কোনটা চাইছে সেটা বলে দেবে, দিয়ে তারপরে তোমার আনসারটা লিখতে হবে। ঠিক আছে? তো কনক্লুশন, অ্যাকুট ব্যাকটেরিয়াল মেনিনজাইটিস is a pediatric emergency. Early recognition, appropriate antibiotics and supportive care are critical to reduce mortality and long-term complications. তোদের বাড়িতে পড়ার জন্য আমি যেটা দিলাম সেটা হচ্ছে রেস্ট ইন্টারক্রেনিয়াল টেনশন, বাড়িতে পড়বে, করে নেবে অ্যাজ এ শর্ট নোট। এবার যে কোশ্চেনগুলো হবে বুঝতে পারছিস তো, কেস বেস কোশ্চেন করবো এবারে তোদের সেমিস্টারে ফাইনালের মতো কোশ্চেন হবে, কেস বেস কোশ্চেন থাকবে, MCQ রাখবো, আর তোর লং কোশ্চেন একটি মাত্র থাকবে, এবং সেটা একটু ভাগ করে নম্বর দিয়ে করা হবে। বেশি বিরাট কিছু করার দরকার নেই, এই হ্যান্ড আউটটি দিচ্ছি, পড়বে, তোমরা প্রত্যেকে একটু ইয়ে করে নিও, যে ইয়ে করে নিও, কপি করে নিও, অথবা আমাকে তোমরা একটা নাম্বার দিতে পারো যেখানে এরপরের লেকচার আমি তোমাদের হ্যান্ড আউট ইমেলে পাঠিয়ে দিতে পারি কমনে। হ্যাঁ, এইটা তোমরা নিয়ে নিবি, প্রত্যেকে যা যা তোলা তুলে নিবি, এটাতে কি হচ্ছে, জিস্ট করা আছে, অ্যাডিশনাল তোরা পড়বি, কিন্তু বই পড়বি। এটাতে একটা জিস্ট করে দিয়ে আমি বলে দিয়েছি, যেটা পরীক্ষার সময় হয় কি, এই জিস্টগুলো থাকলে একদম ঝড়ের মতো তুই উল্টে চলে যেতে পারবি, যাতে প্রত্যেকটা জিনিস মনে পড়বে কিন্তু। ঠিক আছে।